Good afternoon to everyone. It's afternoon here in Miami. My name is Jennifer Lobb. I'm one of the trauma surgery fellows here at Ryder. I want to thank everyone for the opportunity to participate today. This is, I think, my third presentation in the last couple of months about penetrating chest trauma. So, and I appreciate the fellows and faculty from my home institution logging on. I would encourage the fellows on here to participate in these if you have interesting cases, because it's really awesome to get perspectives from experts around the field and around the world. So thank you, everyone. And with that, I'll go ahead and get started. Some learning objectives. So we're going to review some algorithms for management of penetrating chest injury. We're going to talk about indications for emergent chest tube patient or chest tube placement. Sorry, that was a mistype, in stable patients with penetrating chest injury. And we're also going to discuss some operative approaches for management of penetrating chest injury. All right, so this is a case actually from September from Jackson South. I think all three of my cases were from there. It's our level 2 trauma center that we're at in the south side of the city. He came in a little after 8 in the morning on 9/24/21 with a report of a self-inflicted gunshot wound to the chest at home. The vital signs that came out, they told us he had a heart rate of 88, blood pressure of 92/58, and that he was on a non-rebreather mask, and he arrived at 8:56 a.m. He was still on a non-rebreather mask. He just had a 14 gauge IV in place at that time. So when we saw him on initial exam, he was talking, but he was in obvious respiratory distress. So we intubated him immediately upon arrival. Interestingly, and I'll get into the chest wound and show pictures of it on the next slides, but I listened to his lung sounds. He had bilateral breath sounds. His initial blood pressure and heart rate were, so he was, borderline hypotensive, but heart rate of 81. He received 2 units of PRBCs and 2 of FFP. That was kind of going on while we were doing everything else. And I'll explain in the next couple of slides why we gave the blood. But his vital signs did respond appropriately after transfusion. Was never tachycardic. Prior to intubation, he had a GCS of 10. The most significant things, and the pictures are on the next slides, but he had a large aperture on the lateral chest wall. It had exposed muscle and active bleeding from the wound. We examined the wound because obviously we were concerned about a sucking chest wound, but the wound did not appear to be sucking on exam, and the patient never dropped their O2 sats below, really 94%. 92 is kind of the cutoff I use, but he was always above 94%. And then there was also a smaller wound on the left back. We are very cautious about speculating on the trajectory of bullets, for medical legal reasons, but just on our examination, it appeared that it was tangential. The patient was transfused, that's what I mentioned in C, and then he was transfused because he had active bleeding from the wound, not really because of hypotension, and the wound was packed with quick clot. So this is the picture of the wound. Actually, the patient's, you can see the inferior part of his beard right here. Here's a large aperture on the front wall of the chest. It's difficult to see below because there's blood pooling there, but there was exposed and what looked like devitalized muscle underneath that. You can see some significant bruising around. And then as we turned him, this is what we would presume to be the exit wound because it was self-inflicted. And this is, posterior on the lateral portion of the back. So just with the patient in this, you have this patient coming in to your trauma bay. I just want to pull the panelists and ask what you would do next. Any of these are obviously something else if you have that. And I should say we did a fast as well, just to look at the pericardium, and there was no fluid in the pericardial space.
Thank you, Dr. Lobb. Dr. Kasim, your comments, please.
Obviously, this is a significant chest injury, irrespective of whether you observe sucking wound or not. This should be interpreted as this is going to be a sucking wound, and the patient probably has some element of tension pneumothorax, hence he's hypotensive, along with wherever he's losing some blood as well. So prior to intubation, I think you should at least decompress the left chest, even if it is with a needle. If not, you should put a chest tube in the appropriate area so that you can have an effective drainage of the left hemothorax after you've looked at the chest X-ray, of course, if it is available. Regarding the need for transfusion, debatable at this time, but if you have the product available and go ahead, you can transfuse. I wouldn't have any disagreement with that. I think the patient needs to be stabilized. Hopefully you will get some sort of stability with appropriate chest tube drainage and covering of the aperture that you mentioned, and getting the mediastinum coming to the central if it is moved to the right, and then you can think about whether you would like to have a CT of the chest to see if any other problematic area that you may have to deal with. So that's what I would be doing. Thank you.
Thank you, Dr. Kasim. Dr. Bawasir, your comments?
Thank you for the opportunity. This is an interesting case. So I do not disagree with what has been done so far. The first thing before I intubate the patient, I would probably just do a quick ultrasound to look at the pericardium. And you said that there's no pericardial effusion as the cause of his hypotension, because once he's intubated, he's going to collapse and probably won't recover. So that's good. The second thing that I would do, I would probably cover the wound with a three-way dressing, and then put a chest tube, decompress the chest, and then intubate the patient. So I agree with Dr. Kasim. Maybe this is one of those cases that you need to address B before the C, before the A, I mean, because his airway intact, because his respiratory distress is probably because of a problem in the chest, not in the airway. Regarding transfusion, I do not disagree at all. His score is high as a prediction for massive transfusion. Is a penetrating injury with hypotension. So his score to predict massive transfusion is high. So I do not disagree with blood transfusion. Thank you.
Thank you, Doctor. Dr. Baron, do you have any comments?
Yes, I wish Jennifer would have had an option E that says all of the above, because many of these things are happening simultaneously. I do think the patient needs a less chest tube for the compression and intubation at the same time, obtain a chest X-ray, and I would put a line in, but regarding transfusing more blood products, it will depend on what the vital signs are. For penetrating injury, probably keeping the pressure at 90 systolic and the heart rate that he has at 80 would be sufficient. So I'll just wait and see. I will have means to give more blood and fresh frozen plasma. I would just wouldn't move it blindly. The patient stabilized at that point, that will be it, but I will put an introducer to more. And I think that here, obviously, stop the bleed goes first. So if the wound is bleeding, the patient has to go to the OR to stop it. If what you did temporarily didn't work, the patient has to go to the OR. So my option would be all of the above.
Thank you, Dr. Baran. Dr. Ibaturi, do you have any comments? Dr. Martos, any comments?
Yeah, I'd like to ask Dr. Parreira also. So this patient he came here, it became hypotensive. He was bleeding a lot through the chest wall, a lot. So, and arterial bleeding through this tract. So they have a big anterior hole. You are thinking about exactly what happened, how was the dynamics of that, and the situation since we intubate him and the O2 saturation was 96, was 90, never dropped. Our priority at that point was to stop the bleeding, right? Again, the patient was active bleeding, was sanguinated to that wound. And while he was being packed, you never appreciate penetrate to the chest to the pleural space. So was really tracking throughout the outside the rib cage. It was kind of was interesting for us. And then with quick clot, we were able to do a good tamponade, temporarily stop the bleeding. And that's why we did the transfusion and we stopped the bleeding, because at that point C was priority because O2 saturation was stable, and I'm pretty sure, for example, that Dr. Parreira had some case like that before. Dr. Parreira, what did you do in this case?
Antonio, I think Dr. Vaturi raised his hand.
Yes, he did. Dr. Ivaturi, would you like to make a comment?
Yeah, thank you. I agree with what has been said so far, but I'm not quite understanding very well where exactly is the entry wound is. Is it below the level of the rib cage, or is it above the rib cage level, and immediately posterior is the exit wound? So
yeah. So what I was told, the opening wound was in the front and the exit was on the back. But you see, there's a huge destruction on the opening, on the anterior part. So you could say maybe he had the gun on the skin and then had the destruction. So we are trying to understand also what was happening. But what was with his big injury, this injury was not sucking. So for us, that was kind of strange, and he was bleeding a lot higher than the injury protocol.
Yeah, sometimes the rib cage, the ribs, as well as the muscles, the intercostal muscles, when they're shredded, can create a big area of bleeding without necessarily involving the left pleural space. That's what I'm trying to get at.
Right.
So if your ultrasound has not shown any evidence of fluid in the left chest or in the pericardium, and a quick chest X-ray does not show any big hemothorax, then it is entirely possible there is an extra pleural musculature that is actually bleeding because of destruction. So that'll be a nice point to make out by an immediate chest X-ray if it is possible for you to get it.
Dr. Parreira?
Antonio, talking about speaking after Dr. Vaturi is uncomfortable. I'd say I agree with everything. If the patient is bleeding actively, I wouldn't stay with, in the ER. I just pack the wound and go to the OR too. I have seen bad chest wall injuries with many ribs and the intercostal arteries and veins bleeding a lot. Not to the pleura, but outside externally. So I try to, stop the bleeding, as you said. Thank you for coming.
Yeah. The follow-up. So what happened to these patients?
So we did option A, obtain a chest X-ray, and surprisingly, I mean, this is kind of alluding, Dr. Vaturi is on the same line of thinking as us, because we got the chest X-ray, and you can see the paper clip is there where the aperture is. So someone was asking what the location of the aperture was, and you can see that there's no pneumothorax. There doesn't look like there's any blood in the chest. There's a large amount of pulmonary contusion, but actually no pneumothorax. So with everything.
At this point, I'd like to ask Dr. Buzelli. I don't know if he's in here. Dr. Buzelli is our director of Army Trauma Training Department. He's a military. So Dr. Buzelli, any comment regarding this image? Is a surprise for you that have been seeing a lot of penetrating injury? Any comment of blast effects of penetrating injuries, Dr. Buzelli?
Hey, good afternoon, everyone. Yeah, so appreciate the opportunity to talk. The injury that you're seeing, I certainly was initially thinking, you see that anterior wound, it certainly looks like it has a very high risk of being a sucking wound, but it sounds like within a short period of time, you're able to determine that clinically it was not sucking. And so then you're into more of a hemorrhage control mode. And I completely agree that the blast effects, sometimes of the especially military grade munitions, are going to cause some significant lung injury, even if there's not direct chest penetration. X-ray looks like you do have quite a bit of a either hematoma or contusion there. So that's likely going to blossom and continue to create problems for you. The management, though, without the chest tube obviously seems appropriate, as there's no evidence of blood or air to evacuate at that point. So I think we're on the right track going forward.
Thank you, Dr. Buseli. Dr. Lobb?
So just wanted to get any additional comments that people have after seeing the chest x-ray, if that would change your management at all.
So now you have a patient with this injury to the chest. No, that's not sucking, it's a not suction wound. You have a chest x-ray that didn't show pneumothorax or hemothorax, but showed that huge blast effect on the lung. And the bleeding with quick clot and like a aggressive compressing, you are able to stop. So what to do next? Let's change the order. So let's talk Dr. Parreira.
You said you control the bleeding through packing, Antonio. So the patient is stable and there is no active bleeding. Okay, can I consider? So CAT scan, let's do it. Angio CT to see if there is another blast injury to the vessels, the mediastinum and the subclavian. I do that. But at any moment the guy is unstable, go to the OR, because there is a high risk of, there is a high risk of active bleeding in this. Even you can pack, your packs are going to get red, and you underestimate this small amount of bleeding. But if you can go to the angio CT, find a little spot, then can embolize it perhaps.
Let's keep going, Dr. Vaturi. Let's change the order. Yeah.
Okay. You young guys are very, very brave. I'm not so brave. I'm an old man, so I don't like CT scan patient who has just been kind of stabilized with a little bit of packing. So my place for this guy is to be in the operating room under my superb personal care. So I would go to the operating room, explore that wound, see how much destruction I have, debride that carefully, take out all the dead tissues, create more bleeding, try to control it as best as I can with all kinds of hemostatic techniques, okay? And then consider what I need to do, depending on where we are. In the meantime, continue your transfusions, continue to stabilize him. I keep it simple. Thank you.
Thank you. Okay, so we actually...
Let's ask more people. So
yes, sorry, Dr. Martos.
Yeah. Dr. Cassim?
I am old as well, so and I don't like to send patients to the CT scanner when somebody is bleeding, and the quick clot may be a very temporary thing, and in fact, superficially you may see clotting and not bleeding, but he may be bleeding inside somewhere that you have missed. I think this fellow belongs in the operating room, and I think I can see everything that I want to see with my own eyes, and through a posterolateral thoracotomy. And because I'm looking at the chest x-ray, there doesn't seem to be a lot of injury to the right side. It is all concentrated on the left side. Oh, before I go to the OR, I would definitely call one of my vascular surgeons or interventionals just to make him aware that I'm going to the OR, that I might need some help and help later on. And I think this patient needs to go to the OR where I can deal with the blast injury to the rib, the muscle, and I'm suspecting that he is bleeding from torn multiple intercostal vessels, not one, because he's bleeding profusely. Thank you.
Dr. Hodgman? Horacio?
I was letting my colleague, Dr. Bawasir, do the talking today for us.
Go ahead, doctor. Go ahead.
Yeah. Sorry, I pass.
Okay, so so since he's stable right now and the bleeding seems to be controlled, I would probably get a CT scan. I would like to know the trajectory of the bullet. If it's just involving the lungs and the bleeding stopped, and most of the time this can be managed with a simple chest tube. If there's an evidence of major vessel injury, the patient will need to go to the operating room. That's what I would do.
Any other comment, Dr. Collet? I know that you are in a place with not good connectivity, but any comment from you, sir?
Antonio, I think in this case, if the patient is unstable, this patient needs to go to OR. I have some cases that have injuries of only the wall and the muscles and the ribs, and the patients go unstable. So I think these patients staying unstable, go to the OR. If the patient is not unstable today, sometimes I believe if I have possibility, I go to an angio CT. The angio CT is very helpful to avoid incisions or treatments that can be not get some benefits for the patient. Sometimes I go to OR and open and not find more bleeding. So I think that's, if it's possible, the patient is stable, go to an angio CT and see what's happened. Then I can structure a surgery, adequate surgery. So sometimes it's very helpful for us. That's the way I go. I think go to OR if the patient is unstable, and if the patient is stable, I go to make angio CT.
Yeah, to make these things more sort of make things more easy, the patient stabilize the blood pressure. See, he was a responder after 2 units, right? And this makes you have no doubt the patient needed like at least a wound exploration, like Dr. Vaturi said. So, Dr. Buzelli, any other comment, additional comment at this point?
No, nothing at this point.
Okay, Dr. Lobby, anybody else want to talk?
Antonio.
Yes, Dr. Ginsburg.
I think with that type of wound, if you're trying to decide OR versus CT, I would just put the chest tube in as when I see that, because I obviously hit just to make sure if it's not bleeding out from the chest, then and you've got an area that is near, I think, I can't remember because I got here late. Can't remember where the entrance wound was, but if there's a question of a intracostal bleeder, but the guy's stabilized or he's got a zone 1 injury, it'd be nice to know that by sending him to CT once you've made sure that he's not bleeding into the chest. Obviously, if he's bleeding into the chest and he's putting out blood, even though you've transfused him and he's, then it would be worth to take him to the OR instead of CT.
Okay, just summarizing everybody. So Dr. Vaturi said initially could be just chest wall. You needed the chest tube at that point, do a chest x-ray. With that x-ray, need surgery, but go straight to surgery, no CT. Dr. Parreira, most everybody else discussed about placing chest tube. Dr. Parreira and Dr. Collet said maybe the patient could have a CAT scan, and Dr. Again, our colleague from Boston said the same thing. Dr. Vaturi wants to go to OR operating room. Dr. Belwazir CAT scan maybe, Dr. Parreira, the same. Dr. Ginsburg, you would place a chest tube before going to CAT scan. Okay, anybody, Dr. Rivaturi, you want to make a comment?
Yeah, Antonio, I just want to ask about where we are. Are we still in a level 2 trauma center? Do they have a hybrid OR? How far is a CT scanner from the operating room? Some of these logistics can be terribly important. So please give us more data on that.
Yeah, he's at our level 2 trauma center, but had the same staff they work with level 1. That's Dr. Ginsburg Trauma Center. The CAT scan is 30 seconds away from the trauma bay, and the OR is 15 seconds away from the CAT scan. So we have a good setup. You have IR available, interventional radiology, have mass intensive protocol. You have a nice setup over there.
Okay, thank you.
Dr. Lobb, so what did you do?
So we elected to proceed to the CT scanner. We, as Dr. Martos had mentioned, we planned to go to the OR for some type of exploration because the patient had ongoing hemorrhage that needed to be stopped. I mean, it was packed with quick clot, but everyone knows that's a temporary solution. I'm trying to play the video. That's why I took it off because it was, yeah, so sorry about that. I don't know what happened to the video. It was here and now it's not working. I wanted to scroll through the entire CT so everyone could see.
Can you open PACS? Can you open PACS?
Yeah, I can. It's just going to take me a minute. This is a representative image of the CT scan. So hold on one sec. But so I'll skip over this question as I'm pulling up the images because we took the patient to the CT scanner for CTHS to locate the source of the bleeding. The patient these were the vital signs in the CT scanner. So after he came in initially and got transfused, his blood pressure, he was normotensive and he was really never tachycardic. He was.
So Jen, why you trying to find the CAT scan and say, the patient was stable throughout the CAT scan, right?
Right. But completely stable throughout the CAT scan. But however, as we were concluding the CT scan, Dr. Martos and I were there with the patient. We started to notice blood that began bubbling out of the endotracheal tube. So I'll just poll everyone while I work on pulling up the CT scan. So what would everyone do at this point?
Dr. Lobb, can I ask you a question?
Yes, sir.
At the age of 78, you just cannot just give us the blood pressure and the pulse rate and say that everything is stable. You got to give us a little bit more hemodynamic data. What was his lactate? What was his base excess? Any of those data available? Because in this age group, you can't respond or rely on what the normal responses are. So do you have any physiologic data?
Yes, I can tell you what the recess was when we came in because it's our practice. We get, a recess on everyone that will tell us the base deficit. So, and I should have put that in the circulation part. So give me a minute and I will give that data to you guys as well. Anybody else have comments while I'm working on this?
I just want to let you know, Jennifer, instead of resus, so they understand what you're talking about, it's a complete blood gas with lactate and electrolytes, because we're the only ones that know what a resus profile is. I made up that name 30 years ago so that we would know what to ask the lab for. So when you hear resus profile, that only means something in writer.
Was there a hemothorax in the CAT scan or just the pulmonary contusion?
No, there was no evidence of hemothorax on the CAT scan either. And that's why I really want to bring it up for you guys so I can show you the full picture, like the full scroll through of it, because it's actually pretty interesting. But first I'm getting the data on the VBG that was obtained for this patient. Right,
well, so far, we are coming to the picture that Dr. Rivaturi said in the beginning. There could be a tangential wall, the chest wall, Dr. Rivaturi, and then with active bleeding through the chest wall that you need to, at that point you are seeing, okay, you need to do a wound exploration, try to open the wall and try to stop the bleeding the best way you can. And the idea was the CAT scan was because we didn't know this was anything like axillary vessels, etc. Maybe angioembolization should take a picture on this patient. But
Antonio, but you have pulses, correct? You have pulses on that arm.
Correct.
Yes,
you have
correct.
So, and again, we knew the patient need to go to the operating room. That was the plan. And again, since we had blood available, went to CAT scan, it was like a stop before operating room that we did. And Jennifer gonna show us the CAT scan right now.
There it is.
Can do the bone window now, please. We noticed
sure.
CAT scan that what looks like on X-ray, the hematoma or the pulmonary contusion was bigger on the CAT scan, right?
It was surprising how large it was compared to what we expected based on the trajectory of the wound.
Jennifer, I noticed that he had a bulge in the so-called exit of the wound when you look at the first picture that he showed us. That made me suspicious that it was extrapleural and the blood was accumulating between the skin, the muscle, and the rib and tracking backwards.
And I mean, this is, like, as you were commenting on, this is the bulge that you commented on seeing at the, at the supposed exit site, whatever it is.
So the question now is to everybody, okay, I don't know if you need to the CAT scan, you should go straight to the operating room. But what you learn from this injury, right? So I was expecting a big hemothorax or a sucking wound. We never had that. So Dr. Buzelli, with your experience in the military, so what kind of injury is that? So what you can teach us about this kind of injury based on the imaging that the clinical data and the imaging that we found and showed so far?
Yeah, I mean, so it really is with that very large contusion on CT is starting to look like a blast injury. Based on that scan, I mean, again, with no pneumothorax or hemothorax, it seems unlikely that the chest cavity has been penetrated, so that is maybe more the cavitation effect. I know we don't know exactly what the grade or size of the weapon was, the ballistics, but based off of that anterior chest wound, if the gun was placed directly against his skin, certainly the gases and things from the muzzle could explain some of that, but it also seems like it might be a fairly large caliber weapon, even as a handgun, maybe a large caliber handgun that caused that wound. So it is starting to approach more of a military grade type injury rather than a typical civilian. That doesn't look like a 22 caliber U.S. pistol. I do get concerned about some of these because at some point you wonder how badly injured that lung is. That it did the ballistic go through the chest. I've seen a couple injuries that have perplexed me like that, where you're almost certain that the bullet had to go through the lung, but there is no there is no pneumo or hemo like you guys are experiencing. And so I do wonder, again, no proof of this, but just wondering if there's an entity where some of these, the bullet tract is small enough that it actually does penetrate through the lung, but does not actually, seals quickly enough that it doesn't cause anything significant within the pleural space. Again, that's just an assumption after having seen a couple of similar wounds in Afghanistan recently. But right now, looking at that CT, I'm thinking more along the lines of a blast lung type injury because of the proximity of how close that bullet went to the lung tissue rather than maybe penetrating through it. Over.
Okay, Dr. Kassim, your comments, please.
Well, I think we're chasing the red herring here. I don't think this patient has an actual lung injury, in my opinion. I think he probably is right-handed. He shot himself on the left side of the chest, created a big cavity, and it was all extrapleural, but took the ribs, the muscle, like Dr. Venturi has as mentioned. And the bleeding is mostly all extra pleural, extra thoracic, accumulated in the back wall here somewhere, a big hematoma there. And I think that's where the blood is accumulated. The chest tube that was placed did not produce any result of blood. And looking at the chest x-ray, it looks like a lung contusion, but it is not. I think it is all clotted blood in front of the lung. That's what I am interpreting it as. The bleeding is from multiple intercostal vessels and the muscles, like Dr. Venturi has mentioned. Thank you.
Yeah, at that point, you do a thoracotomy or just do explore the wound and try to stop the bleeding on the chest wall with this information so far?
I think with the information that I have from all the CT scan, everything else put together, I think I would not do a thoracotomy. I would explore the wound, debride it, and see what the rib fractures look like to see if I can stabilize or pin it if possible, and definitely ligate the intercostals so that he doesn't bleed anymore, and evacuate the hematoma. I think I would like to keep it simple without going into the left pleural cavity itself.
Okay, thank you.
Dr. Kassim, the initial values for the VBG, his space deficit was -3 and his hematocrit was 42.
Thank you.
Thank you.
Dr. Bewazir, what do you do now?
Thank you again for the opportunity. It looks like from the CT scan, the trajectory went through the lungs only, and luckily the heart is spared. There is some hemothorax. There is a small amount of pneumothorax that I can see on the CT scan. What I would do probably, I would take the patient to the OR to try to debride the wound and try to stop the subcutaneous bleeding, and maybe do a mini thoracotomy, evacuate the chest from the blood, and put a proper chest tube. And we really need to provide coverage for this chest wall wound. And the other problem that we're having now is the hemoptysis that he's having. He's bleeding into his lungs through the bronchi. And maybe I would consider doing a bronchoscopy in the OR and see where that bleeding is, try to stop the bleeding into the airway. Thank you.
Thank you very much. Let's go to Dr. Anything to add, Dr. Hodgman?
I was not participating again, but just a few comments.
You have to.
And I am not sure that this is, again, without looking at the wounds, is difficult. But he was shot. If he shot himself, he had to use a handgun. Handguns, the bullet can deform, can cause really severe injury, but they don't cause cavitation. Cavitation, you need to have a bullet traveling close to the speed of sound in the tissue. The fastest, an average, the speed of sound in the tissue is around 4,400 feet per second. So you need a rifle able to reach, the bullet to reach those speeds. And even an AR-15 is like 3,500 feet per second on average. So it's close, but it's not even the speed of the sound in the tissue. Those cause cavitation. Handguns, usually the speed is like 1,200 feet per second. So usually they don't cause cavitation. They can cause severe injury. So I seem to have this degree of injury in the lung for the handgun. The bullet has to have traveled through the lung. And probably, as Dr. Bawazir mentioned, he had adhesions there. And so if it's bleeding into the airway, that becomes a problem because you have to worry about blood going into the other side and causing chemical pneumonitis. So I will be doing everything possible if I go to the OR to secure the airway with a double lumen tube. Is that not an option? A bronchoscopy with a Fogarty number 8 passing parallel to the ET tube when the bronchoscopic guidance, that may be another option. But the concern here is the bleeding into the other side, who might give him a severe pneumonitis that might kill the patient later rather than what happened with his initial injury. Thank you. And again, Dr. Bawasir is representing us today, so I want to be in the back seat. Thank you.
Antonio, can I make a comment? This is Albert.
Yeah, Albert, you had this question also, Dr. Haldeman, because the information you had was self-inflicted, but you never know. And the injury was like for a high-speed kind of gun. You know, we receive information, but you're exploring possibilities. Yes, Dr. Baron, please.
Yes, I just want to make a point that I'm just looking at the time sequence, the correct, you have to stop the bleed. And it doesn't seem like we have stopped that on this patient. That should be number one. Jennifer, push up the labs there for a second. Would you mind sharing them again?
I can't do that, Dr. Verone, because
Okay.
it's patient information. I can't share it.
Okay,
Sorry.
so, well, with the flash that I got, the patient is having progressive drop in the hematocrit, patient with 40, then went to 30, then you give him 2 units of packed cells, the next hematocrit is 28, and the base deficit is run from 11 to 14. So everything is showing that there's progression. It's more base deficit, dropping in the hematocrit as you're giving blood. And I think the answer is the patient we have to stop the bleed.
Dr. Verone,
so this was afterwards.
Yeah, Dr. Verone, all the ABGs, VBGs you're looking at are at 10-something a.m. We were already in the operating room at that time. So those are all from the operating room.
Okay. I still think that if the patient had pulses when he came in and the patient is not stable, you're giving blood and the patient is not responding to that, you have to stop the bleed first before you do anything.
Right, but Dr. Verone, and thank you for your comment, but the point is initially the patient did respond after we gave him the blood products. His blood pressure.
If the patient responds, blood pressure stabilizes, then you can do all the scans you want.
Right.
But not
Right.
Otherwise.
Right. And that's the point of the case, is that he responded after giving him the initial transfusion.
So at this point, the patient just finished CAT scan. That's the image that you have. The blood pressure is 120 over something. The heart rate is okay. He's saturating 100%. And then you just start to see some blood coming through his ET tube, okay? But hemodynamic, he's not hypotensive at this point, and he's not desaturating at this point. While we are keep leaving the patient on CAT scan and going to operating room. So let's keep going. So Dr. Parreira, what did you do? What you do this information? Would you do a thoracotomy, explore the chest wall? Dr. Vaturi will be the last. Dr. Parreira?
Yes. Okay.
I think Dr. Jaime Villaquiran. Dr. Jaime Villaquiran has.
Yes, thank you very much.
Raised his hand.
Thank you. I did. Can you hear me?
Yes.
Yes, looking at the CAT scan, I don't know if Dr. Lobb can tell us, there was a hemothorax, but if you look at the esophagus is dilated and there is fluid in that esophagus. Behind
the patient has a history of esophagectomy with a gastric pull-up. So that was probably
I wasn't told about that.
Thoracotomy, a previous thoracotomy, or how was the operation?
Now we're getting to the mixture of these things that if you don't have the whole history,
well, I mean, I will say he didn't have any thoracotomy scars on his body.
Probably.
Yeah, and the family was, not able to provide us any further information about when it was not done in our system, unfortunately. So I didn't have access to the off records.
Well, Antonio, I will give you 2 reasons because I believe this shot is extra pleural and there was no adhesions only. Because first, if you have this amount of energy through a lung injury, you would certainly have a fistula, some air leaking, not sucking on, but a huge hemothorax first. The second point is that it seems to me that, of course, there is, the question here is not the blood pressure, but actually, if the patient is bleeding, this is the question. It's not exactly, because you can give it fluids, but you're going to, get worse some time after. So first thing, I'd do the CAT scan. For me, this is a bad blast injury. It's a high velocity missile, and you have a bad lung contusion. And okay, let's go to the OR to control the bleeding through the wound. But I would certainly do what Dr. Hoffman just said. I would just try to put a tube in the right bronchus to protect the right lung at this moment. And it prepare, because it probably will develop, being 78, is going to develop some kind of ARDS. And we have to be prepared before the hypoxia and the hypercarbon. I'll be prepared for that.
Can I intercede because I didn't finish 1 second?
I'm so sorry, sir. I apologize for that.
Having that history of having had an esophagectomy, the lung on the other side, sometimes you open the pleura on the other side, and that lung may be stuck to the chest wall from his previous surgery. And he has a severe trauma of his chest cage, and this lung has stuck, so it hasn't come down. And you can sometimes have that the lung doesn't come down, and you have a suckling wound, you have a bleeding wound with all this debris and everything, but the lung hasn't come down and hasn't proven. But as previous informed, there is alveoli that's open to the airway, and that's why you're getting air and all this blood going through the lung, coming up through the ET tube. Thank you.
Dr. Parreira?
I've just said I'll do the OR pack, control bleeding through the wound, bronchoscopy, try to put a tube in the right lung. I wouldn't do a thoracotomy. If I don't have a huge hemothorax, why would I open a thorax? There's no air leakage. There's no blood in the thorax. Go through the wound, hemostasis through the wound, and protect the right lung. That's what I do.
Okay, thank you. Dr. Ginsburg before Dr. Vaturi?
Can you hear me?
Yes.
Antonio, did he have, I don't remember, did he have a left thoracotomy scar? I didn't realize he had an esophagectomy.
He did not have a left thoracotomy scar.
So once again, this make things simple. You know, if he would have had a chest tube already in, you know, when he came in with that type of injury, then you would have had that as a diagnostic, very minimal diagnostic procedure, which would let you know if he ever became unstable or and he was bleeding into the chest or whatever, that you couldn't just rely on the wound itself as the source of bleeding. But overall, I mean, obviously, you know, you're not going to do a thoracotomy on a guy who's not bleeding out of his chest and not being unstable, although his so you would just be going to the OR to get exposure of that wound. But I think the chest tube was a simple, very small, easy to do procedure right away once he was intubated to prevent any problems like tension pneumo developing or all of a sudden exsanguination.
Thank you. Dr. Vaturi, you need a master in this case, sir.
No, it's very difficult. First of all, let me congratulate Dr. Lobb for a wonderful presentation. She peeled the onion for us slowly and slowly and slowly, so that, you know, the case became more and more different as we progressed. But let me just make a few comments. Don't take it too critically. One is that I never take a patient out of the resuscitation area or the operating room to a CT scan or angio suite unless I make sure that there is no continuing base deficit. It's not proceeding in the right direction. I don't care what the blood pressure is. I don't care what the pulse rate is. Especially important when the patient is 78 years old. Second, now I'm in the operating room looking at this wound. The left chest tube has been decompressing the left chest. If there is not too much air coming out of there, not too much blood coming out of there, we are not concerned about a tension pneumothorax or excessive bleeding with the left chest. So I would proceed with debriding, as we said, the intercostal area, the entire wound, musculature, and proceed as it takes me. If it takes me into the left chest, I may have to open the left chest because most of these ribs might be completely destroyed and causing extensive damage by themselves into the lung tissue. So, and now while the anesthesiologist is telling me now we got blood in the endotracheal tube. Now I'm really concerned that there is a compression injury to the lung. So we need to decompress that right bronchus, make sure that this blood does not go onto the normal side, which is the right side. So the next thing would be I would ask the anesthesiologist to place a double lumen tube, occlude the left bronchus so that he will maintaining one lung ventilation on the right side. Most importantly, do not turn the patient onto left lateral thoracotomy. You got to do this anterolateral thoracotomy so that you don't let that blood escape into the normal lung. That's the most important thing. Maintain good oxygenation, continue your transfusion, continue your resuscitation, and take it step by step. If we have to get into the left chest and debride that devitalized lung tissue, so be it. You got to do it. So that is how I would manage this patient. Thank you.
Dr. Vaturi, yes, we agree with you. So we are going to the OR at this point to finish stop the bleeding of the chest wall. But our concern is that we saw the CAT scan, that the hematoma, the contusion in the lung parenchyma was much bigger than it was 10 minutes ago, 15 minutes ago to the chest tube. And then you put a patient, Dr. Lobb, you're going to say the procedure, put the table, and then adding to that, the patient started quickly to have a lot of bleeding through the AT tube. So Dr. Lobb, what did you do now?
So yeah, so we actually, I mean, we did pretty much everything that everyone said. You know, we just decided to go once we saw the bubbling from the ET tube, even though there was no evidence of, you know, a pneumothorax or anything on the CT scan. We were concerned that the injury was more severe than we had initially thought. So we took him to the OR. The bronchoscopy was performed. You know, we talked about double and single lumen tubes. So another option, if you think the patient's in extremis and anesthesia doesn't necessarily have time to switch out to a double lumen, you can use a single lumen with a bronchial blocker, which is what we planned to do. However, the bronchial blocker wasn't really available. So we weren't able to actually decompress the lung completely, which made the case a little bit more difficult. And I think one of the reasons that we elected to extend our incision to perform a formal left thoracotomy, because we needed to get adequate visualization of what was going on.
Let me ask you, did you ask anesthesia to just push the endotracheal tube in further?
Yes, we definitely asked them to do that several times, but I just don't, and they did, but I don't know that it ever, you know, got far enough where
one other option is to just go ahead, do a left thoracotomy and immediately clamp the left bronchus.
Yeah.
So that
or like do a high-low twist or something like that.
Yes. So you protect the right side.
Can I make a comment on the double lumen tubes?
Yes.
Okay, so ideally, if you have a big lung contusion and blood coming out, the ideal tube, if possible, is a double lumen tube. And you do not have to blunt the lung. With a double lumen tube, you get perfect isolation and you can provide ventilation to the right lung, and you can provide CPAP or a different level of ventilation. You can even put 2 ventilators, so it's good isolation. Now, if it's not possible, technically it may be different. If the patient was a difficult intubation, it's difficult to change that too for a big sucker like a double lumen tube.
Right.
If that's the case, then you can use a bronchial blocker. I am shocked that at Jackson South, you couldn't find a bronchial blocker. It's like saying you couldn't find an IV in the operating room, because we use those all the time. Now, the disadvantage of the bronchial blocker is that now you have to block the lung and you lose the entire ventilation in there. Now, doing a right main stem is just temporary. When you do a right stem, you're gonna block the right upper lung. So instead of having, you're gonna have a half a lung ventilation from there on. So that's not a good idea. Maybe just temporarily, but here, again, ideally, it should be a double lumen tube. If that's not possible, then you can go ahead and put a bronchial blocker. And the last resource would be to put a endobronchial intubation. You have to be desperate and bleeding out to do that.
So now is the point you need on the masters because Dr. Varone said we push this to the right side, and then the decisions keep saying. So, Dr. Ivaturi, you are able to start to open the wound, and then you start to find the arterial bleeding through the wall. We're able to ligate some arterial vessels on the pectoral vessels, etc. We stop the bleeding to the chest wall, so the patient had no more bleeding there. But then anesthesia was saying he started to sanguinate through the ET tube. A massive amount in a way that I tried to do bronchoscopy, I just could not do, was really sanguinate to there. An amount and a rate that I never saw before was really sanguinate to there. And then we performed a thoracotomy, and I saw a lot of adhesions to the lung, as expected after esophageectomy, whatever. But then the lung never went down because it was not because the lung was full of air, because the lung was just full of blood, right? So that was what happened. And anesthesia said then the patient became hypotensive because he has sanguinate through the bronch to the trachea, and how would you stop the bleeding right now? So Dr. Lobb, we're gonna show some pictures. What happened?
Right.
That's the question. What to do now, right? Yeah.
Did you consider clamping the pulmonary artery there and doing a pneumonectomy?
Yeah. I'll clamp the pulmonary hilum on the left side.
That's a death sentence.
If I make one thing that one trick when you don't have bronchial blockers, because I've been in places that we were poor enough and we didn't have bronchial blockers, but you always have a Fogarty, is to use the Fogarty number 8, and the Fogarty has a wire inside, so you need to bend the tip of the wire 30 degrees, just distal, proximal to the balloon, because otherwise you cannot direct and can run parallel to the main ET tube without getting the cuff. And you have to put it under bronchoscopic guidance, and you might go even distally in a case like this. But the other thing I would worry in a patient like this, which I expected the reason he doesn't have a hemothorax with the additions, is that he might develop air embolism. And he might not, first of all, patients when they bleed into the airway, they die from suffocation, not usually, they don't have time to exsanguinate. Or they get such a bad ARDS afterwards. But the other possibility in this patient is that they might get an air embolism, particularly if they're hypovolemic. So this is something to really be prepared to deal with. So that lung needs to be isolated. Dr. Ivaturi, as always, had an excellent point in keeping this patient flat rather than rotated to the other side. And another option, which I know it sounds like a little bit crazy, but I've done many crazy things in my life, is to abort this to a median sternotomy. I don't think the heart was involved, but if it's involved, it's easier to repair through a median sternotomy, and you can really do a left lower lobe lobectomy through a median sternotomy. It's difficult, it's not easy, but it's doable. So that's.
Dr. Guzelli. Dr. Guzelli, any comment? Dr. Parreira?
Clamp the hilum. This moment, game over. Clamp the hilum. If the patient stabilized, you can think and doing some tracheotomy and ligate the vessels, but I would be very concerned. Just as Dr. Hoffman just said, air embolism is a real possibility for this guy. Have this kind of blood in the airway, you know, which direction the air goes, and I do clamp the hilum, and if the guy is unstable, I'd consider damage control procedure, perhaps later even a resection of the lung.
Would you do a tracheotomy?
Well, do we have the holes or not? Did you find the holes? No. So
no holes.
So the guy, it's really a missile, high velocity missile injury. It's a blast injury. We won't find something to ligate. I think it's just a matter of clamp the hilum and proceed with pneumectomy. Sorry. If the guy is okay, otherwise you put just you clamp the hilum, damage control procedure, and you think this later.
Okay, Dr. Vaturi, please.
Yeah, I think I would clamp the hilum at this point. Dr. Hoffman had some very good points, very well spoken, and Look, clamp the hilum, see what he does, see if you can reduce the bleeding, stabilize him in the operating room for another half an hour or so. Leave the hilum clamped, take the patient to the ICU, resuscitate him, come back, and for another day. That with damage control. It's really one of the most complicated cases I have heard about. So you got to take.
The patient has a lot of adhesions. The lung has a lot of adhesions, and was a nightmare there. So Dr. Lobb,
sure.
Yeah, so I mean, we tried first.
One second. I got to make a comment. Can't let this go. I would not clamp the hilum. If you're going to clamp in the whole hilum of the lung, he's going to die. They do 78-year-old man with a left hilar clamping. He's just going to get into basically right heart failure. He's going to go into heart failure.
You're probably right.
I would not do that. You know, you might be able to get away with it for a minute or two or three, but usually within a very short time, is my experience, which is only in the experience of maybe 3 or 4 cases that I've done pneumonectomies for. And all of them, unfortunately, after pneumonectomy have died. And these are young patients. I probably would not clamp the hilum for more than a few seconds, or maybe partial clamping where you're seeing bubbles and bleeding, but I don't like that idea. Maybe use my fingers on it, but clamp, I don't like it.
Dr. Kassim and Dr. Bawazir, after any other comment? Dr. Kassim?
If you do anything like clamping the hilum, pulmonary twist, pneumonectomy, this patient will die, period. So the only way you can salvage this patient from hemorrhage, you want to stop the bleed. You need to find out which lobe is affected. Perhaps you isolate that lobe and take care of it. Anything more than that, I think it'll be a death sentence to this patient. Sorry.
I totally agree with Dr. Ginsberg and Dr. Kassim. This patient, especially in his age, is not going to tolerate hilar twist or ligation of the hilum. I would try to control the bleeding with the minimal maneuver possible. Like start with the basics. See if they can see the hole. Try to do a wedge resection, for example. If wedge resection doesn't work, try to do a lobectomy. I would try to leave the ligation of the hilum last resort.
I agree with that totally. But we were told that he was exsanguinating from that left lung. So at least temporarily control the hilum and see what it gets you.
Yeah, it's a tough situation.
It is a tough case. Definitely a tough case. Yes, I agree.
Yeah. So we did the following, Dr. Lobby. That's what we did. At this point, the patient multiple transfusion protocol bleeding. Again, they could not ventilate the patient, oxygenate the patient anymore because of the active bleeding. A lot of blood to the airway, to the radial tube. So what did you do?
Yeah, so first we tried a tracheotomy where the lung was injured to control hemorrhage. That wasn't very effective, and the anesthesia was having difficulty ventilating the patient. So then we actually we performed primary suture repair of multiple left bronchial injuries. We just went and identified them individually and ligated them. I think we did that for about 4 or 5. And then at that point, it seemed that we had some sort of, we had hemostasis.
You open the tracheotomy, then have like an open wound, then start to just to suture everything, all the edges, and to stop the bleeding, right? And what happened, Dr. Lobb?
So then we just performed individual primary suture repair of the bronchial injuries. Yeah. Because after we did the tracheotomy, that wasn't successful. So we individually ligated them.
And Antonio, when you did the tracheotomy, you did it without a stapler, correct?
I did it with a stapler.
We used a GIA stapler.
The idea was actually to open the hematoma and try to direct ligation of the vessels.
But you did use a TA, correct?
Correct.
Beautiful.
And then we were able to stop the bleeding. Actually, with a lot of, was not easy, but to stop the whole bleeding. And there's a picture after that done,
Right.
with no bleeding happening and no big air leak happening, right?
Right.
Great job.
So the chest was, the chest was packed with laps, as you saw in the previous picture. We then placed 2 chest tubes. We felt pretty confident that we had hemostasis at this time, but the patient had received large volume transfusion, and here is your ABG at the end of the case. So, this was definitely, everyone mentioned damage control. This was definitely a damage control procedure. So we elected to leave the chest open. We actually closed the skin, left the 2 chest tubes in place, and we sent him up to the ICU with a plan to return for chest closure at a later date after the patient had been resuscitated. This is a picture of his vital signs actually in the operating room at the end of the case.
Remember, oxygenation not good. We either consider ECMO, you call the ECMO team.
Right. So yeah. So actually, he went to the ICU after that. He did require, he had some desaturations in the ICU. We bag ventilated him, and he improved after the bag ventilation. We did all the maneuvers that we have. We started him on paralysis for vent desynchrony and to help with the desaturations. We were obtaining ABGs every 2 hours. And actually by midnight, his gas had improved. I had him on a volume assist control because I was trying to see how much volume he was losing with this persistent air leak per breath. He was losing about 50 cc's of volume. We had him on 450. And then we also spoke with our ECMO colleagues at Jackson, Maine, to have him as an early evaluation for ECMO, because as everyone mentioned, this is a 78-year-old man. And we were very concerned about him developing, a complication from this, especially ARDS. But unfortunately, he was not a candidate because, the severity of the lung injury, that even if he was, to go on ECMO for a while, it would unlikely that the lung would be able to heal. And he was just an elderly gentleman. He was continued to be transfused on hospital day 2. So he did not return to the OR on that day. He returned to the OR on hospital day 3 for washout of his left chest. The team oversaw the tracheotomy. They put a placement of a closed suction drain in the subcutaneous space, and they put another chest tube in. And after that,
I think Dr. Ginsburg took him back to the OR, right, Kiki?
I don't know.
Right. And after that, he did have an
Antonio, I really don't remember.
Was it? Okay.
After that, he still had some air leaking from the chest tubes, but the air leak was much improved. So the intervention, when the chest was closed, did help him. And so this is his hospital day 4 chest x-ray, though, as everyone can see, this is really starting to, it looks bad on the affected side, but even on the right side, it's starting to look a little bit like ARDS. But actually, he really did improve after he was taken back. And on hospital day 4, I was on call again that day. When I saw him early in the morning, he's on 50% FiO2. The air leaks had resolved. He was started on tube feeds. So, I'm just saying the tube feeds to show that we felt that this patient was clinically improving. But unfortunately, overnight, when I was on call, he just had this sudden decompensation. So he became hypotensive with, desaturations. He had to be escalated to 3 pressors overnight. He was, previously on 50% FiO2 and had to go up to 100%. He was already paralyzed. We gave him epoprostenol and we started proning, started him on broad spectrum antibiotics. We were just doing everything that we possibly could for this gentleman. And we talked to the family that we were really worried about his prognosis. He did remain full COVID, but unfortunately, the next morning, he was still on high dose pressors. He went into asystole and prone position, which, as everyone knows, is never a fun thing to happen. They flipped him over immediately and called the code blue. We came up there. They were performing CPR when we got there. We never retrieved ROSC, and we pronounced him deceased at 7:27. Yeah. So I wanted to go through some,
So Dr. Lobb, let's ask everybody. So the patient survived for 5 days and was going the right direction. They suddenly had a sudden deterioration. So any comments about the procedure, the management, anything else? I would start with Dr. Faturi.
Dr. Antonio, please tell me, how did you do the tracheotomy without having the holes in the lung? How did you decide where to put the stapler?
I went through the hematoma and create an opening and just put the stapler. I need to open the hematoma. Again, for me, the patient was dying was a huge hematoma, expanding hematoma to the lung, not bleeding to the chest wall, but leading to bleeding through intraparenchymal bleeding to the bronchus. So I don't know, Dr. Vaturi, there's a name for this procedure, but it was the only thing that I could do, to stop the bleeding right now and work it, right? I open, have a labia like this, then start to suture everything.
Antonio.
Well,
yes.
Sorry.
No, go ahead.
Go ahead, doctor. Go ahead.
I just want to say that it's a fantastic case and it was a very difficult one. Major decisions need to be made every step of the way, right? Step by step, and you attack them, and you came up with some brilliant solutions. Not all of them can be correct, obviously. They can be second guessed, but you did a great job. And probably the prognosis was already decided right from the beginning because of advanced age and the extent of injury. But what I would really like to see come from this case is that Dr. Lobb has done a fantastic presentation. He can write it up very nicely as a case report and present it to the Pan American Journal of Trauma and Critical Care, because a lot of people have missed this excellent conference. And I think we should give them an opportunity to learn from these cases like this. I have never seen a case like this in my entire 40-year career. So this is not something that all of us are blessed with, in our careers. So people should read about it and learn to approach problems when they come across in the clinical situation by innovative thinking, rapid thinking, and by using all the material that is available to them. So can you please make that happen? I would really like to see that. Thank you.
Thank you.
Thank you, Dr. Lobb. You have a commitment to do to Dr. Vaturi right now. Okay. Dr. Buzelli, are you still there? So anything to add from the military experience? We really, if you are there, it would be very important to listen to your comments or experience in the military for this kind of injury. Dr. Buzelli? Is he there, Valeria?
He's connected, doctor, but I'm not sure if he can talk or if he's available.
Dr. Parreira?
Well, I learned so much. Thank you very much, Antonio, Dr. Lobb, for this excellent presentation. I'm thrilled. I've learned a lot. I just want to make a point about the high-low clamping. I think this is to be the first maneuver to control the bleeding. I know it's a problem. Yeah, the right heart failure is a problem, but you can't do a good tracheotomy without clamping the hyaline. So I do it first, calm down, calm the situation, resuscitate a little, like Dr. Vaturi said. Try to open this is something I learned. I haven't done this before. Try to open the hematoma in a blunt injury like that. I've done this for through and through bullets, but not for lung injury. And the other thing that I've learned is that perhaps I'd like to hear your thoughts, Antonio. Perhaps putting really a forward catheter in the right bronchus, left bronchus, to just control the bleeding in the lower lobe without clamping the vascular area of the lung. What do you think about it? Perhaps thinking, something different that could have done. I don't know. What do you think about it? Thank you very much for that case.
That could be an option, but what was worrying me that the amount and the blood and how fast this intraparenchymal hematoma was happening. Again, the lung. I said you keep asking, is the right lung is intubated? Is selected right intubation because the lung could not go down. The lung was so distended and full of blood, and keep expanding. Intraparenchymal was bad. And again, we try to go to the high, but so many additions, and like that again, we start to think about outside the box, and and this patient received the amount of blood he received, and again, was not like was continual bleeding like a liver injury that as bleeding. It was bleeding that amount through the tube. It was critical and massive bleeding. Dr. Cassim, looks like you.
Dr. Antonio, several months ago, Dr. Supar, one of your favorite fellow, presented a case something like this, injury to the bronchial vessel on the right side. And what he did was he packed it and left the chest open, went to ICU and came back and was able to salvage the patient. The only salvage that I've heard of, and I have that in my collection of cases that I'll like to go back and look at it again. But this is a phenomenal case, and I think you gave it your very best. And like Dr. Enrique Ginsberg says, most of these patients, they are looking at the day they return back to their Lord. Sorry. The results of this type of injury, this type of bleeding, where the blood is going to the other side, they eventually die of heart failure.
Our friends from Boston.
I would like to congratulate you on this case. And one more thing I'd like to say, thank you so much for the opportunity to be one of the panelists among great speakers and great icons in trauma surgery in the field. And I'm really honored to be here with you. I really learned a lot from you guys. Thank you very much for the opportunity.
Dr. Bowser, this is all about the Pan-American Trauma Society. The idea to share knowledge, to exchange information, experience, and to have young faculty and residents and fellows, everybody join our society and keep moving forward. That's what we want to make our society move forward. Thank you for participating. Please participate every week if you can.
It's an honor. Thank you so much for the opportunity.
Dr. Hodgman, any additional comment?
So yeah, you kind of took the words out of my mouth. This is what the value of this conference is. I learned so much today, and the way that we learn from so many really kind of legends of trauma surgery, like Dr. Ivaturi, but also this is the value that the way you handle this case, Antonio, is you managed to solve a problem that you haven't seen before. And this, meaning that expansion in the lung, that you don't have room and you have the additions, whatever. And this is the essence of a trauma surgeon. We are prepared to deal with whatever nobody has seen before, and we need to find a solution. And the reality is that you found a solution, because this patient was exsanguinating and bleeding into the airway, and he didn't suffocate in the OR, and you controlled the bleeding. After that, he developed ARDS, and really not too much that can be done about that. But this shows what the value of this conference, and I'm sure that one of us in the future will use the knowledge from this conference to solve a similar case. One piece of there's something I should publish in the Journal of Anecdotal Surgery. I have one case once that the patient developed a very similar problem. And I trained at Mass General, where kind of like at that time I was in the 2000s, everyone that would walk through the door would get an epidural and he would get inhaled nitric oxide for whatever. So everything was inhaled nitric oxide. And one thing I learned with the nitric oxide, that it works great until it doesn't work anymore, because the patient developed tachyphylaxis. So we had this patient, and the only place where he could go for ECMO, he didn't have insurance, so we couldn't transfer, was a young patient. So somebody said, okay, let's try nitric oxide. And my opinion was that that was useless, because in a few days, the patient will develop tachyphylaxis. But this was the only case where it really worked. because the chemical pneumonitis for aspiration of blood resolves relatively quickly if you can get the patient over the hump. So this is another thing to take into consideration when you have a patient like this, using nitric, based on the experience of one case, that really totally unscientific and unsupported evidence, but that's something to consider. If you don't have ECMO, maybe try inhale nitric oxide and will put you over the hump. That's it. Thank you very much.
And Dr. Hodgman, and just remember everybody, the Pan American Journal of Trauma, Critical Care, and Critical Surgery, Dr. Vaturi was the editor of the journal. Now Dr. Servizoli, you're open for great case, for people to share the experience, and that can be a good forum. If you have any good case paper, please remember to submit it to our journal. Dr. Collet, I don't know if you're there, but Dr. Collet, you usually has good case and good solutions. Can we make your comment about this? Lessons learned, what else would you do? Anything else, Dr. Collet, could add to the case?
Antonio, it's a very great case. It's very difficult to treat. It's not usually injury in the in civilian way. When in the cities, you don't see usually these injuries, but the treatment is very important in what to do. And I agree with all comments. I know that the great problem in these patients is and the comorbidities that the patients have, and for cross-clamping the pulmonary ileum in this situation, I agree with all comments, because when you clamping the ileum, you increase the pulmonary artery pressure, and the right cannot. There can be very, very dangerous in this situation. So I think the great problem is how to treat these patients in this age. Sometimes it's very difficult to treat patients, make some damage control surgeries or some critical maneuvers to control the hemorrhage in this patient. But in some patient, it's not possible, and you can make the problems with these patients. So I have congratulations for the presentation. Very, very nice and nice comments. Thank you.
So Dr. Thank you, Colette. Dr. Lobb, please go over your final slides quickly, and then I'll ask Dr. Vaturi for the final comment.
All right. So just wanted so a couple of things I wanted to talk about is, the role of chest tube placement at initial presentation. So something that we really went through when we were discussing this case before is the WTA algorithm, which Western Trauma Association, which I'm sure most of you have seen, but it really is, the go-to article on penetrating chest trauma, and it was released in 2014. It's still very valuable today. The algorithms are based on patient stability. So, if you have an unstable patient or a stable patient, and really if you have an unstable patient, the recommendation is to go to the operating room. If you have a stable patient, really the initial assessment is based on what the chest x-ray shows. But the interesting thing that, that's kind of an outlier with this case, which is why it's kind of an unusual case, is that the patient on the initial chest x-ray really didn't have an evidence of a hemothorax or pneumothorax. So, when you have a patient that falls outside of the algorithm, I'm just, interested in learning, because if everybody would just automatically put in a chest tube on this patient, even though it's not really in the algorithm, is that just something that you do know from expertise? I mean, me being relatively new in all of this. I just wanted to know if anybody had any comments about that. Otherwise, I can keep going if Dr. Martis would like.
Jenny, let's keep going, please. Then we're going to ask Dr. Vaturi for the summary of the case.
Absolutely. So we already talked about the single lumen endotracheal tube. That's actually from the article that a single lumen is preferred. I think that's just because of the urgency of the situation, but we already talked about the role of double lumen tubes, talk about positioning. There's obviously multiple ways that you can position the patient. They recommend a gram-positive antibiotic coverage, which is something small, but something I didn't know before reading the article. These are descriptions of thoracic interventions, and we can use a variety of these. And I think everyone has used at least one of these in their practice, and we've discussed some of them already, the role of a sternotomy, but really the choice of the operative approach is dictated by the patient stability, the mechanism, and obviously the surgeon preference or experience. Pulmonary tractotomy versus lung resection, this kind of gets into what we were talking about before. I'm not really going to talk about the hilar twist, but, these are all, different spectrums of options that you can use for management of penetrating lung injury. But really the most important thing, and I think that this is the salient point related to this patient, is that mortality rate is related to the severity of the injury, not necessarily the surgery you perform. So I really do think that even though this patient did survive till hospital day 4 or day 5, that the injury was quite severe, and that's probably what led to his demise. Tractotomy is associated with a higher incidence of infectious complications, and it's actually not associated with shortened operative times or survival. In terms of what, you're doing some sort of operative intervention for penetrating trauma. I mean, 27% to us, I think, doesn't sound like a lot, but 27 out of 100 patients are going to die, and that's all comers. It increases if you have to do a concomitant laparotomy. And then the pneumonectomy group, the mortality rate was 69.7. I've not done many pneumonectomies, but I've never seen anyone survive. So just the bottom line to emphasize that this was quite a severe injury. It was more severe than we initially thought. He was, a responder to blood products and was, by our impression, stable after that. The role of the management really depends on stability. The role of the chest tube placement to me is still a little bit unclear, because some of the trauma surgeons at our institution had commented when I presented this case before that, you really should put a chest tube in these patients in the beginning. But I don't really, I believe that that's certainly supported by their experience, but it's not necessarily supported in any of the algorithms. I think the major thing for us is, even when a patient seems stable, like when they're in the CT scanner, you have to be looking for any clinical signs that would require operative intervention. So we were very fortunate, Dr. Martos and I were there with the patient in the CT scanner. And once we saw the bubbling and coupled with the CT scan, we looked at each other and said, this injury is probably more severe than we initially anticipated. So we're going to need to be prepared for that. I already talked about the last two, but those were just kind of the final take home points from the case, things that I learned. So thank you very much.
So Jennifer, you did an amazing job. So Dr. Vaturi, has been a privilege, absolute privilege to have you participate in these meetings.
Yes, thank you.
And I would like to have the honor to have your final comments. And this meeting is recorded. This meeting is going to be the Pan-American Society platform forever. People can watch and learn. So if you can give us an honor to make your comments and the teaching points for this case, it's going to be great.
Actually, you all have been very, very kind to me. I appreciate that. I think Dr. Lobb has done a fantastic job. You guys did a fantastic presentation of the case, as well as managing the case, step by step, standing there next to the patient. In general, I would like to say that we have to do things not because the algorithms demand, but the patient may showing you that is different than what the algorithms are speaking of. So if placing a chest tube is the least dangerous thing you can do, there is no harm in placing a chest tube to make sure that there is no pneumothorax that is not evacuated, there is not overlooked hemothorax, etc. So I would say that placing a chest tube is probably okay. And after that, it's questionable whether the patient should go to the operating room or the CT scan. In general, as Dr. Kasim has mentioned, we old people, old surgeons, pardon the expression, think that the patient who is bleeding, who is unstable, potentially unstable, must be in the operating room rather than a CT scan. Under direct control, if you have the luxury of hybrid OR, CT angio suites, etc., that's a different thing. So there are a lot of things to be learned from this. And I think Dr. Lobb has has presented this very difficult case in a rational, coherent, step-by-step way that was very much appreciated. And you guys have done some remarkable things in this patient that you don't ordinarily read in textbooks. So I think it behooves you to teach the younger residents and colleagues of some of the things that you have noticed. And please describe it exactly as you did in the operating room. How you use the instruments, how you approach the bleeding points, etc. And for my final comments are that there are two things that kill these patients. One is active hemorrhage, and second is hypoxia. So if you can somehow control these two things, then you'll have a very better outcome. Not in this 78-year-old patient, but I think the lessons that you learn from this 78-year-old patient can very easily save a 50-year-old or a 40-year-old in the future. And that would be a fantastic blessing for the patients and for our trauma surgery. Thank you very much. I appreciate it. I'm so glad I was able to participate today. Thank you.
Thank you, Dr. Vaturi. It was an honor for us. And the last Pan American Trauma Society conference of the year going to be next week. And then they're going to go for holiday breaks. So let's try to connect to finish this amazing year well. We're going to have a great case presented next week. Thank you, everybody, for participating. Thank you, Valeria, for helping us. And Dr. Lobb, amazing presentation, a great fellow.
Thank you, Dr. Martos. Thank you, everyone. Thanks for participating.